I maybe read too much into this conflict statement, but I actually declared a conflict. The study I'm going to be talking about is a comparison of primary care models across the province. And so I'm going to be talking about some pretty hard quantitative data. But in case my passion for community health centers, social determinants of health, or interprofessional teams creep through, you know that CHCs pay my salary. So this project was done in collaboration with ISIS. Really, it was ISIS that drove this study. I was an investigator with Dr. Rick Glazier, and he was hopefully going to be able to come here today, but he had a board meeting at the ISIS office. So if people don't know Dr. Rick Glazier, he's the lead scientist for primary care at the Institute for Clinical and Evaluative Sciences. He's a physician at St. Mike's Hospital, and he's overall a pretty great guy. He took my cold call saying, you know, would you work with me? So he was an awesome guy to take my call. So basically, this was my problem a couple years ago when I was tasked with figuring out how to quantify complexity in CHCs. We are great storytellers, community health center folks. We pat our own backs and we tell these amazing qualitative stories about the work we do, but we really didn't have any evidence. So that was my first goal, to really try to quantify who we see and the complexity of clients that we see in CHCs. So my goal, working with ISIS, was really to tell the CHC story. I wanted to basically do a secondary analysis to provide a comprehensive social picture of CHC clients and clinical complexity within CHC clients. Now, working with ISIS, of course, they wanted to make it bigger, and they said, well, while we're at it, we've never had access to CHC data before, let's make this a big comparison of model studies. So that's where we ended up. So we've gone through the history a few times, and I have to laugh because my picture of solo practice before the models came into effect may have been attributable to me having worked with Kathy at the beginning of my career. So to me, she was the essence of calm. And anyway, it was just funny because I saw her picture and it was a bit more frenzied. And I won't go over all the models again. This is sort of the timeline that has happened over the last few years, really in an effort to increase accessibility and quality of care within primary care through various incentives and structural changes. But I just wanted to remind everybody that really community health centers have been working in parallel with all these other models for over 40 years. So there's over 75 CHCs right now that operate in 110 communities. So we're really out there, and we've been a model that has existed for a long time. I do want to spend a few minutes on this slide, though, because it really talks about the differences of the different primary care models. You can see that? So I've really focused on the community health centers, the family health groups, the family health networks, and the family health organizations. I talk about FITs in my future slides, and just to orient you to the way we organize different groups is we've got the FINs and the FOs, and then we have the FITs. And the FITs are representative, of course, of FINs and FOs, but if they're FINs on their own or FOs on their own, they don't belong to a FIT. If that makes sense. And I think it will to this audience, which is always funny, because I feel so funny saying that to other groups. But the big difference for the physician reimbursement within the CHC sector is, of course, that they're a salary modeled. So they're an employee of the community health center, and they receive a salary. Where all the other models are either a blended capitation or a fee-for-service model. We have a governance model in CHCs that we have community boards of directors, where all of the other models are physician-led. We all have after-hours requirements. We, in CHCs, we're the only primary care model right now that's accountable to the LHIN. So we report data to our LHIN, and we have accountability agreements that hold us accountable for the services that we provide. All the other models except for CHCs have formal enrollment, so we don't formally enroll our clients to CHCs. We register clients to CHCs, but really the whole enrollment process sort of flew in the face of our model of care when as I say in my more dramatic moments. We have a lot of community outreach and health promotion in CHCs, which isn't as noticeable in the other models. And the two capitation models have a loss of bonus payment for outside primary care use. And I think this was really highlighted in the paper. I don't want to spend too much time on it right now, but Dr. Glazier really drove home the point about the 18.6 potential loss of the access bonus for your clients or patients when they go to the emergency department. And so when we're thinking about sort of why the results happen the way they might, I mean that possibly is a reason. It's sort of incentive that has the reverse effect is what was intended. So basically, I want to go over the methods really quickly. This is what I call the alphabet soup, and it's so all of the participants in the study included the CHCs, the FIGs, the FINs, the FOs, the FITs, people who aren't enrolled, and we've referred to them as non, and what we've referred to as other groups, and this includes places like Seton House, the Sault Ste. Marie Primary Care Clinic, and Sudbury. So there's a whole bunch of groups that are sort of too small to be a group upon themselves, so they're clustered into this other group at ISIS. So the inclusion criteria was any resident in Ontario who had a visit with a physician between April 1st, 2008 and March 31st, 2010. So it's kind of ancient history now. We're going through and doing the study again in CHCs to cover the next 2 years. It'll be interesting to see what happens next. It included almost 12 million Ontarians in the study, so it was a massively large study as far as I'm concerned. And about 90% represented urban folks and 10% rural folks. One of the great things with working with ISIS is that we were able to do what's called data linkage. So from the person's individual's health card number, we were able to link up to all of these other databases. So for me, that was really important because I didn't want to focus on sort of how complex our provider's day was. I wanted to focus on how complex the client was, to look at the whole client, patient journey through the healthcare system. So what we did is we looked at CHC data. So I extracted a subset of data from CHCs, from every CHC in Ontario, so 75 CHCs participated. And it was a bit of a tricky thing because we don't bill OHIP, we have what we call encounters. So our encounters represent each visit that a client has with our physicians. And we pulled one random diagnosis because often our providers will record multiple diagnoses. We had to, in order to make it fair, because everyone else uses billing data, we randomly selected one diagnosis per visit. Please ask me any questions about the methods as they come up. Again, we linked up to the registered persons database. We used all the OHIP billing claims. We looked at NACRS for the ambulatory care data. We looked at discharge abstracts. We looked at the Ontario Drug Benefit Program to get a measure of poverty. We looked at 2006 census data. You name it, we linked it. So it was a pretty comprehensive data set because we really wanted to get a picture of the social and clinical complexities. When I was doing my preliminary review of how to measure complexity, I did a literature review initially to decide how to even start thinking about measuring complexity in primary care. And pretty soon I went down the path of looking at the Johns Hopkins ECG methodology. Of course, this was developed at the Johns Hopkins School of Medicine, and it's used worldwide. It's been validated in Canada, in BC, Manitoba, and Ontario. And what it does is it groups disease burden by all of the diagnoses that a person has over a 2-year period of time. And it's really based on the premise that patients using the most health care are often those with multiple and sometimes unrelated diseases, and that clustering morbidity is often more of a useful tool for predicting utilization and looking at specific disorders. So right away, this one seemed to really jump out as being a good way of measuring case mix in primary care. There's a lot of groupers available that are really good at doing it in hospitals, but this seemed to be good at primary care. It includes social issues, it includes all sorts of episodic issues, it includes comorbidities, all sorts of information. I've got a little picture here to make it simple. Basically what the Johns Hopkins methodology does is it takes all the patient diagnoses over that 2-year period of time and it puts it into this bit of a black box algorithm. So we don't really quite know how the black box algorithm works, but what it does is it takes all of those diagnoses and it clusters them into what they call 32 adjusted diagnostic groups, and there are 32 meaningful clusters. And from those clusters, the ADGs are meaningful upon themselves because that gives us a measure of comorbidity, but from the adjusted diagnostic groups, we can get levels of expected resource utilization and what's called the SAMI, and that's a standardized ACG morbidity index. And that's a really useful number, and I think the reason it's so useful is because it's so easy to understand. It's a measure of overall morbidity plus expected resource utilization, and I'll be talking about that later. ISIS also has what's called disease cohorts. They're really just like disease registries. We chose ones that we thought were most relevant for primary care. We use diabetes, asthma, COPD, diabetes, and then mental health cohort, which is stratified by serious mental health or psychotic mental health and non-psychotic mental health. And the psychotic mental health disease cohort includes people with schizophrenia or bipolar disorder. Now, one of the problems with the disease registries is CHC folks aren't included. All the clients that are seen at CHCs aren't included in these disease registries because, of course, we don't bill OHIP, and that's how ICES gets their data. So what we did is a similar algorithm. So if a client had a visit with a physician over that 2-year period for one of these illnesses, actually if they had to have it twice, we included them in the disease registry for this purpose. So again, basically the analysis was really simple. It was just a secondary data analysis, and we used that health card number for data linkage so we could get the full picture of the client health experience through the sector. We did descriptive analyses, just looking at some simple proportions and t-tests, just to figure out sort of the client and patient complexities, both social and clinical. And then we did Poisson multiple regression analysis to look at the predicted risk-adjusted rate of ED visits, because we really wanted to adjust for sort of the 5 drivers of emergency department use, which are age, sex, rurality, how sick a person is using their SAMI, and their level of income. So we wanted to get that risk-adjusted ED rate. And of course, because we developed data linkage, we got Sunnybrook Health Research Ethics approval. So this is a legit study. So I'm going to go over a bit of the data, and I think all of this data really gets us to the point of talking about emergency department use. So just to orient you to the slides, we've got all the different primary care models on the bottom. So we've got CHC, FIGS, FINS, FOS, FITS, the non-group, and then the other group. And this slide is really just looking at age group in years by primary care model. And it's the non-group also includes all the pediatricians. So that's why they have the largest group of kids under the age of 18. But if you look at the CHC and the non-group, we have the greatest proportion of clients under the age of 44. And the only reason I've included this slide, like I've excluded tons, you can read about them in the paper, but this, of course, age is related to morbidity. So I think it's important for us to keep that in mind, that the different variations in age across the different sectors. The only other sort of difference within the different primary care models is that FINS had the greatest proportion of people over the age of 65. So this one is something that the folks at ICES practically roll on the floor over when they see, and it's funny for CHC folks, we see people who live in poverty. That's just what we do. And so for me, it was kind of like it validated what I already knew. But these income quintiles are built that 20% of the population should fall into each of the income quintiles. And so an income quintile, they're adjusted for household size and cost of living. So it's an income quintile here in Stratford would be different than an income quintile in Toronto. So they're built by Stats Canada that 20% of the population should fall into each of the quintiles. And what you can see is that the lowest 2 income quintiles, which sort of means poverty, are really overrepresented in CHCs, which again doesn't surprise me. We actually target our services for people living in poverty. But I think what ICES found really interesting was that they were underrepresented in some of the capitation models, so the FINS, the FOS, and the FITS. And all the other models were fairly similar. Now that's a population level measure of poverty. So what I mean by that is we use postal codes to define that. So what we wanted to do was look at more of an individual level measure of poverty because of the problems of using postal code data. So what we did is we looked at the Ontario Drug Benefit Database as another measure of poverty. And here what we've done is we looked at anyone who'd had a prescription paid for by Ontario Works, Ontario Disability, or were classified by the means test as being a low-income senior. And you can see here that again, not surprising to CHC folks, that the people who had received ODB assistance in the last 2 years was quite highly overrepresented in CHCs, and similar across all the other models. So this slide is just looking at mental health status across the primary care models in Ontario. Again, serious mental health has been defined by ICES as being either schizophrenia or bipolar. In the province of Ontario, the prevalence is about 2%, And in CHCs, it's about 6%, and all the other models sort of follow that provincial average of about 2%. Whereas general mental health is higher in the other models compared to CHCs. So you can see that in the FIGs and the other models and FOs, almost all the models have higher general mental health concerns than the CHCs and the FINs. Sorry, I'm whipping through this pretty quickly. I've got the reference to the paper at the end. Okay, so it sort of goes with your slide. We looked at asthma and COPD. It was slightly higher in CHCs, and all the other models were similar, except for the non-model, which had a fairly low prevalence of COPD, which I think again speaks to the young population. What I found really interesting looking at this data on an individual basis, I looked at all the individual CHC data, is there were clustering in certain areas. So like this area for sure, and in the north. In the north there was a large proportion of people with COPD. So diabetes didn't really differ across all the primary care models. Non, again, had the lowest proportion of people living with diabetes, again, I think because it's so correlated with age. So this wasn't terribly surprising to anybody. It was about the provincial average of diabetes. So this is the SAMI, and so this is what I was talking about being an overall measure of morbidity and expected resource utilization. And so what this slide indicates is that CHCs on average have about 85% greater health needs than the average Ontarian. So the SAMI has been standardized at 1. So what that means is a score higher than 1 means your clients are more complex than the average Ontarian. A score of less than 1 means they're less complex. So this is averages. So you can see here that almost all the primary care models had slightly higher than the average Ontarian, probably because they're being seen. And the again, with the young people, had a slightly lower than the average Ontarian level of expected resource utilization and overall morbidity. Yeah, so I think that speaks for itself, but it is quite a useful measure because it gives you that sort of snapshot of overall morbidity and expected resource utilization in one easy to understand number. We use that number in the emergency department utilization because we wanted to look at the observed emergency department utilization, and here you can see that CHCs, FINs, and FITs all had quite high emergency room utilization. So that's our actual rate. So as I've been going out to CHCs, that's been really important for us to focus on, because that's the actual rate of people going to the emergency department. But what came out quite loud and clear, and you can see it in this slide, is when we looked at the risk-adjusted rate. So when we actually factored in how sick our clients were, how poor our clients were, whether they lived in rural or urban areas, the age and sex of the clients, we realized that there were several models that actually had lower than, well, a few models that had lower than expected. So you can see this with the blue and red bars. So the blue bar is the observed rate, and the red bar is the expected rate. So what this means is that the expected rate is given your client, or your patient, sorry, I should just client/patient, complexities, they're going to the emergency department either less or more than what would be expected. So you can see in the CHC model and the FIG model, the clients that are going to the emergency department actually less than what would be expected. So it is that they're going a lot, but they're going less than what would be expected given their level of sickness, their age, sex, their income, and their rurality. So we just did a quick ratio because it makes it really easy to understand. So this is just the observed over the expected. So if it was equal, it would equal 1. So here you can see quite clearly that CHCs have their clients going to the emergency rooms on average 20% less than what would be expected, whereas FINs, for example, have their clients going to the emergency department 25% more than what would be expected. So it's just, I think, an easy to understand way of representing the data. So from this really brief presentation, I think we can see that all the models had profiles that were really quite different from each other. I think CHCs are distinct from the other models in their focus on the needs of specific populations. So at CHCs, often we're organized around what we call intended populations. And so what that means is that unless you're part of that intended population, often CHCs won't even see you. So you have to meet intake criteria and you have to go. And often that intake criteria is that people are living in poverty, they have mental illness, they're homeless, there's all sorts of characteristics that people actually reach out for and help for those specific populations. And I think this showed up in their profiles. I think, again, that's why we weren't terribly surprised by these profiles, but they were strikingly different than the other models. There was more poverty. I didn't show some of these slides. We had greater numbers of newcomers. We had higher levels of morbidity and comorbidity, as well as ED visits that were considerably less than what would be expected. The family health groups were almost all urban. There was very few family health groups in rural areas, and their morbidity and comorbidity profile was very similar to Ontarians on average. And the FINS, FOs, and FITs, the capitation models, had lower proportions of patients living in poverty and slightly higher than expected ED utilization based on this model. I wanted to draw attention to this group here because it's the non-group. And it was the third largest group examined, and those are the clients that aren't attached to a model at all. And I think this sort of deserves some discussion because it was the third largest group examined. So the FIGs and I think the FIGs and the FOs were the biggest groups, and then the non were the third largest group. And they were more likely to be male. They had lower morbidity and comorbidity, but they had fairly high emergency department visits, so their visits were higher than what would be expected. And I think that's where we really see that gap in primary care. So I thought this is where we could kind of come down to the discussion of what potentially could be driving these ED rates in CHCs. And I think both family health teams and CHCs are designed to meet community needs. However, CHCs are fundamentally different. You know, and this one is peer-reviewed, this paper was peer-reviewed. I got kind of offended by that because I was like, well, we're all supposed to provide primary care. We're not different. But you know, when it comes down to it, we really are a bit different. We reach out to people who are the most hard to reach out to sometimes. We have a broad range of interprofessional care. So when we talk about interprofessional care, that includes outreach workers, harm reduction workers, social workers, dietitians, art therapists. Like we have all sorts of providers that work within our team. We do community development outreach, you know, all sorts of things that are different than the family health teams. We are community governed, which you know may or may not make a difference in this, although the community often dictates what we're going to be doing they help decide our strategic plan. And I think the big thing is we serve disadvantaged populations. So when I've gone out to individual CHCs and we've talked about this data, they've said, well, you know, that low ED rate may not be a good thing. Sometimes our clients feel so disenfranchised, they can't go to the emergency department. They don't speak English, or they haven't had a shower in 2 weeks, or and we've created a climate at CHCs that's so comfortable, the physicians have said, you know, I have to drag them to the hospital. So I think that speaks to some of the next steps because we want to look at CTAS levels to actually see where and when people are going to the hospital. And then I think there's that whole funding capitation model thing that we talked about. I mean, the capitation models do lose up to 18.6% of their access bonus if people go to see another primary care provider in the community. And so it doesn't, you know, Rick would call it a perverse incentive. You know, he really feels quite strongly that this might be a driver of why the emergency department rates are higher in those capitation models than the other models. So there was quite a few limitations, I think, when you're working with big, huge data sets like the ICES data set. You're using proxy measures, and one of the limitations that we thought as CHCs it was almost going to be a showstopper was the non-insured. So Jan mentioned that CHCs are served non-insured. It actually wasn't nearly as big as we thought it was going to be. I think in total there was 11.5% of the clients that could not be linked. So that doesn't mean their data was excluded. All of their CHC data was included, but of course it couldn't be linked to the other databases. But what I thought was interesting was it was a bit of a myth in CHC that we see the non-insured. I think we see the people who are waiting to get insurance. We see the people that are transiently insured, so they're the folks that live in shelters that get beat up and get their insurance, their ID stolen. But often if you look at folks over a 2-year period of time, they have a health card number at some point, so we were able to do that data linkage. In CHCs and family health teams, the nurse practitioner data is not included in these registries, so we didn't include CHC data. And what that resulted in is 22% of CHC clients not being included. So you can see that in CHCs, a lot of nurse practitioners manage the bulk of care. So those 22% of the CHC clients never saw a physician during that time period. The patients who died before April 1st, 2010 were excluded. That's sort of just an ISIS rule. And when you think about that, you could be excluding the folks that are actually the sickest and the most complicated out of this study. So I think that's a bit of a limitation. It was cross-sectional data, so we were looking at it just during that 2-year period. So we weren't able to distinguish whether physicians actually changed their practice profiles or their patients before or after all of these transitions. So that was a limitation. The encounter data versus billing data, I think this may be more significant than we think it is, because all the other models use billing data and we use clinical data. And so we used our EMR and pulled from diagnosis, and then we tried to replicate it by pulling a one random diagnosis. But I think, I keep hearing about these top 10 diagnostic codes that people use when they do billing. Well, we recorded issues, address, and diagnoses. So I think that was definitely a limitation that underrepresented the complexity in all the other models. Mediation wasn't explored, and what I mean by that was we didn't look at the availability or appropriateness of resources around the emergency departments. So that could have definitely been on the mediational path, whether someone chose to go to the ED department or not. So that's something we're thinking about in the future. And triage level was not included in the ED data, so we weren't able to look at those 4s and 5s and look at the actual true emergencies. So that's something I'm actually pitching to the CHC network tomorrow at the ED network, to look at sort of a more fulsome report looking at hospital data, readmissions, CTAS levels, to really dig deep into what's going on in the models. Another limitation, which I'm not sure about in the other models, but really speaks loud and clear in the CHC models, is what's called the ecological fallacy. So it's when you've got, you see this picture of a condo with pools on each of the balconies beside sort of what looks like fairly low-income housing. Because some of the data is based on postal code data, those income quintiles, if you're trying to compare the people living in the low-income housing with the same postal code as the people with pools on their deck, you're going to have skewed data. And so we found this a lot in some CHCs like South Riverdale, Sandy Hill in Ottawa, Parkdale, so sort of those really cool gentrified areas where people want to live, but there's still a lot of poverty. So this income quintiles may or may not be representative of your practices. And finally, data quality. I think data quality right across the board. When I go to CHCs, they scream that we've got poor data quality, but I think probably everybody in the room would say the same thing. So the next steps and implications, I think we want to look at a longitudinal analysis to really understand the impacts of the various primary care models. The value for money keeps rearing its head, and I really want to get my head wrapped around that. I think it's important for us to understand the value for money. I think we really need to understand why people are going to the emergency department, so to look at those 4s and 5s and see why people are going to the emergency department, because that's really what we can manage with primary care. And I think for me, it really highlights the importance of a population planning perspective. I think all of the models have a purpose, and I think, seeing the data, seeing which different models do things really well, suggests that we all need to work together to have good primary care in Ontario. And that's it. I got the paper. It was published as an ISIS investigative report. It can be found on the ISIS website, and then I put my contact name and Rick's. Please feel free to contact us if you'd like any other information, or if you want the paper. Feel free to email me, I can send it to you, but it's also on the ISIS website.